Thank you so much, AI Scientific Committee, for this opportunity. I'm Dr. Nilesh Kumar, and I am going to talk about value-added services in low-profit setup. So these are my financial disclosures. So what is a value-added services? Let's start with that first. So you have your OPD services, that is the core of your hospital, and then you have an IPD services. So these is what patient pay for, directly pay for. They pay for your consultation fee, that is the OPD service that you're providing. You are doing an OCT, that is an OPD service you are providing. Similarly, they are paying for cataract surgery, retina surgery, that is the surgery, the service they are providing. But if what you do, if you hire a call center to book their appointment, they are not paying for that. So it's a value-added services. You are adding value to the service that you are providing. So it can be in-house value-added service, or it can be also outside the hospital, that is was for patient experience, like what we do as patient education on social media, making YouTube videos, and creating awareness, something like that. So now, how to decide which VAS is for you? So there are services that patient needs, and then there are services that you want to offer. There are endless number of services. You visit any hospital, you see, and you want to offer that service to your patient, but probably they might not improve your turnover. You provide that service and it's not helping you. So if there is an intersection in between where the patient, what patient needs, what you want to offer, and if it is improving turnover, that is the VOS that you should think about and start implementing in your practice. So let's discuss some bottleneck and pain points that I faced during my initial days when I joined my father's practice. So there was a very haphazard appointment system at my place. Billings and accounts were out of place. Health record was not kept at all. The OPD workflow was messed because if some patients started shouting, they were taken first. So ultimately, by the end of the day, almost all the patients in waiting area started shouting because they saw that it is getting them earlier. Then investigations and reporting, again, it was very immeticulous. Then IPD workflow was quite meticulous, but still the records were not there, discharge and follow-up. And then inventory management was totally out of place because everything was managed by some staff. So what I started with is VAS and appointment system. So once I joined, I created a website because patients had a waiting time of 2.5 months. And when they had to come to the hospital, get an appointment, go back and remember that after 2 months they have an appointment. And they traveled all the way from 200 kilometers, 300 kilometers just to get an appointment. So when I created a website, they can do it by their home. They can choose their slot. They have to come at 11 o'clock, 12 o'clock. Whenever they want, they can come. Similarly, after 3 or 4 months, I started a call center. A call center is an outsourced one where it is a 24-hour 1800 number. What they do is they book the appointment online. So anybody can call and book an appointment at their preferred time and slot. Just a day before the OPD appointment, they get a reminder call that you have an appointment. So even if it is 2 days or 3 days or 1 week, they tend to forget that there is an appointment. So they get a call and they are told at that time that please be on time. This is your time. Don't come before it. Don't come after it. And please bring only one attendant with yourself. So earlier, with each patient, there were 2, 3 attendants. Now with constant reminder, that has come down, and we have around, the average is around 1.5 right now. And then they also call about follow-ups. So if I remember a patient that had a complication and he has not come for follow-up, I just ask the call center to give a call, and they come. Similarly, what I did is a value-added service in OPD workflow. So right now, what you see are unit economics of meticulous examination. If you want to do, you do an ARNCT, then they go to optometrist, then a primary examination is done by a consultant, then the patient gets dilated, then cataract and fundus evaluation. And if glaucoma or anything else has to be done, they have to come for other visit. If OCT has to be done, they wait for OCT angio, and then they come back again to consultant, and at that time they are dilated fully. They don't understand what you are showing them on OCT, and they probably will come again next day to again understand and then get the treatment done. An alternative workflow, what everybody does nowadays is the optometrists themselves dilate, so you save 1 hour of waiting time. But again, the problem is you miss on pupillary evaluation, and NCT, if you have to do a planation again, you have to call them another day. So both of them, the waiting time, uh, total waiting time is around 4 to 5 hours, and this was displayed in Singapore Eye Hospital, that you have to wait for 5 hours if you want to get a complete examination. So Singapore, the most premium eye institute of the world, has to do that. Can we do something differently? So what I did is this all I told. So what I did is I asked my patient to get a Claris imaging done. It's a 75 lakh instrument, but all of my patients get it for free. Autoref NCT, a Claris image, go to optometrist, come to me, uh, almost a 200-degree view of fundus. So if it is normal, I don't have to dilate them at all. If there is a pathology, they understand that, okay, this is a microaneurysm, this is a hemorrhage that is there, this is a neovascular membrane that is there. And within 30 minutes, the patient is in and out if there is normal routine refraction or something. If the patient is having cataract, if they're high myop, they definitely get dilate. We don't. If they are complaining of floaters, flashes, definitely we don't compromise on dilatation at that time. So what it has done around is a faster turnaround time, more happy patients. The patients who are premium, like doctors, lawyers, judges, bankers, they are now coming to our hospital because they don't need to get dilated for their annual diabetic checkup. Then dilated has come down to 25% from 100%. All of our patients were getting a dilated fundus examination when I had joined. So it has, like you can say, a surrogate way, they have increased patient flow and revenue turnover. Similarly, in VAS and follow-up. So everybody calls a patient for 1 week follow-up. And what we do, we see that they are seeing clearly or not. And then we tell them, okay, you start your head bath or whatever precaution that you want to tell. We can do that same by calling. You call up the patient, my call center calls up the patient, ask them how are you doing, everything is fine, no complaint, please start taking bath. Any complaint, please come. Now, 100% of the cataract patients that were visiting us at 1 week, they are now visiting directly at 1 month, and we are not losing. If they are complaining, we tell them that please come. They also feel a personal touch that, okay, doctor is concerned with me. His office has called and told me to take bath. They take bath. So what it has done is enhance the patient experience and also freed up my OPD time. I can see fresh patient in that time and increase the turnover. So that's how you build. Any value-added services, is it increasing your turnover? If it is increasing your turnover, it's worth investing in that. So that call center is, I am spending around 50,000 for that, just for the call center, and then there are certain added expenses on that. But it is generating me around 1.5 lakh of revenue in this indirect method. So with that, I'll end my talk. Thank you.
Very interesting talk. I think so you have invested a lot to increase the, so how much is has it increased the turnover in your?
Yeah, so right now we are, when I had joined my father's practice, my father was seeing around 35 patients OPD because he wanted it to be limited. He was working very limited hours, but his full potential was to see around 45, 50 patients. Now with, I have joined and our surgical load has increased twice. Like I am operating around 18 to 20 patients per day. In spite of that, we are seeing around 100 to 110 OPD.
How did you increase your footfall? That's what I would ask.
So once the patient is like, when we are
mouth to mouth practice?
Mouth to mouth practice, yeah, we have not had.
Digital
my
marketing
father's practice, the waiting period was like the patients were waiting for 2.5 months to get an appointment with him.
Okay.
That was not a problem to get the patient. The problem was their experience was not that good because they had to wait for so long.
So you that invested on patient satisfaction.
Yeah.
Any questions from the audience? Thank you, Dr. Nilesh.
Thank you.